Hey there, and welcome back for another deep dive with us.
Great to be here.
Hope you're having a really good day out there. And since it's May, it feels like a good moment to remember this is Mental Health Awareness Month.
Absolutely. Such an important focus.
Yeah, definitely. And kind of tying into that, today we're going to get into a skill that's just, well, it's fundamental in healthcare, isn't it?
Yeah,
Especially in mental health. We're talking about therapeutic communication.
that's right. And we'll be using insights from Therapeutic Communication by Townsend and Morgan to really, unpack what it is and why it's so crucial.
Right. So the mission here isn't just about like understanding how to be polite.
No, not all.
We want to really explore the core ideas, the principles, and importantly, how this stuff actually works in practice in healthcare settings.
Exactly.
Yeah,
It's way more than just being nice or having good manners. It's a core skill.
it really is. And as the source material points out, the way we communicate can genuinely change the game for a patient, particularly in mental health.
Hmm.
Our words can, either calm a situation down or, unfortunately, make things worse, escalate distress.
Right. They can empower someone, help them move forward in healing, or, yeah, unintentionally re-traumatize them.
That's a heavy thought. Good communication can really open doors to a recovery while the opposite can slam them shut.
And maybe the first thing to clarify is how this differs from just, regular social chat.
Good point. Like talking with friends.
Yeah. Social communication is usually like a mutual thing, back and forth sharing.
Yeah.
The therapeutic communication, it's got a very clear goal.
Okay.
It's laser focused on the patient's needs. It takes conscious effort, real intention, definitely self-awareness and discipline from the healthcare provider.
That's a big shift in mindset, really, because
Sure.
if you think about what's on the line in mental health care, miscommunication isn't just like awkward.
No, it's far beyond awkward.
The source highlights some serious potential fallout, doesn't it? Things like incorrect diagnoses.
Absolutely. Or patients maybe not sticking with their treatment plans. It can increase their distress, their suffering, and in the worst cases, actually lead to harm.
Wow.
And nurses, in particular, are often right there on the front lines of this.
Yeah, I can see that.
They're frequently the ones having these really intense, sometimes very difficult personal conversations. So their ability to communicate therapeutically, it's just vital for keeping patients safe and, creating that feeling of empathy.
Okay, so let's dig into the communication process itself then. It's obviously more complex than just words going back and forth.
Oh, definitely. You can think of it like a loop, right? A continuous flow between the sender and the receiver.
Okay.
But in mental health settings, that loop can get, well, it can get disrupted quite easily. Think about how symptoms of mental illness themselves, psychosis, paranoia, can fundamentally change how someone interprets a message or even sends one.
Makes sense.
Then you add in things like emotional triggers, maybe past trauma getting activated, or even basic communication challenges like aphasia, or say how someone on the autism spectrum processes things differently. All these can be real roadblocks.
You mentioned a powerful example earlier, that video from 2023, the nurse and the veteran in the ER.
Yes, that's a perfect illustration. What was so striking there was the nurse's conscious approach.
How so?
Well, instead of reacting with maybe alarm to the veteran's obvious distress, she made very specific choices. She kept eye contact, but it was soft, not challenging. Her tone of voice was steady and calm.
Okay.
And crucially, she sat down, got on his eye level. That immediately changes the dynamic, makes it less hierarchical, more supportive.
Right, less intimidating.
Exactly. And her words were just as deliberate, short, simple, slow phrases. Things like, I see you're upset, followed by, I'm here to help.
It's incredible how those seemingly small things, the eye contact, the tone, sitting down, those short sentences, how they seem to cut through the intensity.
Mm-hmm. It really underscores the nonverbal aspect.
Yeah, it makes you think about all the messages we send without even speaking.
Absolutely. Her nonverbal cues, her calm presence, were probably just as important as her words, maybe even more so, in stabilizing him. It's such a clear example of how thoughtful interaction, both what you say and how you are, can de-escalate things.
Which leads us neatly into that distinction.
Yeah.
Verbal versus nonverbal communication. We use words, obviously, but there's this whole other channel happening simultaneously.
Totally. Verbal is the language, sure, but it's also tone, speed, volume. Nonverbal is, well, everything else. Facial expressions, eye contact, how you hold your body, touch, even silence can be a nonverbal cue.
Silence, right. We'll come back to that.
And what's fascinating, and something the source really emphasizes, is that often the nonverbal stuff, that reveals the real truth. More than the words sometimes.
Like our bodies betray us.
Kind of. Or maybe they tell a more honest story than our conscious words allow. It's like there's a disconnect sometimes.
That definitely rings true. You see it all the time. Someone says one thing, but their whole posture is saying something completely different.
Exactly. The book gives the example of, say, a teenager on an inpatient psych unit. They might say, yeah, I'm fine, but at the same time, they're avoiding eye contact, maybe clutching their arms really tightly.
Right. Classic signs of distress or being closed off.
The words say fine, but the body screams, not fine.
So how does a clinician handle that mismatch? What's the therapeutic way in?
Well, the example response is really good. The nurse might say something like, you say you're okay, but I notice you seem quite tense right now. Can you help me understand how you're really feeling inside?
Ah, so you acknowledge both things, the words and the body language.
Precisely.
Mm.
You validate what they said, but you also gently point out the nonverbal contradiction, inviting them to share more authentically. It's about bridging that gap, creating safety for the underlying feeling to come out. That connection is it's so key in this work.
Okay, so let's get practical. Let's talk about some of those specific therapeutic techniques you mentioned. These are the tools in the toolbox, right?
Exactly. These are the intentional strategies clinicians use. And one that often surprises people initially is using silence.
Silence. Yeah, that feels counterintuitive. In normal conversation, silence can feel awkward, like you need to fill it.
It absolutely can in social chat. But in a therapeutic context, silence can be incredibly powerful. It gives the patient breathing room
Breathing room for what?
to think, to process their own thoughts, maybe to access difficult emotions or memories like trauma. The example given involves a patient who's feeling suicidal and is initially very quiet.
Okay.
Instead of peppering them with questions, the nurse just sits with them, present in that silence. And often, that non-demanding presence is what allows the patient to eventually feel safe enough to start talking about what's really going on.
So it's about offering presence without pressure. That makes sense.
Yeah.
What else is in the toolbox?
Restating is another really useful one. It shows you're listening actively and helps confirm your understanding correctly.
How does that work?
So if a patient says, I just feel like giving up, the nurse might restate it as, so it sounds like you're feeling hopeless right now, is that right? It validates the feeling and gives them a chance to confirm or correct you.
Got it. Validation and checking understanding.
Then there's clarification, crucial when things are vague or ambiguous. If a patient says, they're watching me, a clarifying question would be, when you say they, can you tell me who you mean? Helps get specific.
Okay, that cuts through potential paranoia or confusion. What if the conversation just goes all over the place?
That's where focusing comes in handy. If a patient is jumping between topics, maybe avoiding something difficult, you gently guide them back.
Like,
You've mentioned some worries about your job and also feeling lonely. Could we go back for a moment to what happened yesterday that made you feel so alone? It helps keep the conversation productive.
okay. And you mentioned one more earlier.
Offering self? It sounds simple, but just conveying your presence and availability is huge. Saying something like, I'll be here for the next hour if you feel like talking, or even, I can just sit here with you for a while. It offers support without demand.
These seem like subtle but really powerful ways to build connection. You also mentioned a real-life story from the Washington Post.
Yes, a really moving one about an ER nurse with a woman experiencing postpartum psychosis. It beautifully illustrates silence and empathy in action.
What happened?
The patient was clearly distressed, perhaps disorganized in her thinking. The nurse, instead of pushing hard for information, mostly sat quietly nearby, sometimes knitting, offering just brief, gentle words of reassurance.
Wow.
And the impact was profound. When the nurse's shift ended, the patient told her, you didn't make me feel crazy. Just think about that. That quiet, non-judgmental presence was deeply therapeutic.
That's incredibly powerful, just being there, really being there.
Sometimes that's the most important thing.
Okay, so we've talked about helpful techniques, but it's just as important to know what not to do, right? The non-therapeutic approaches.
Oh, absolutely. And these are often things people do with good intentions, but they can really backfire and damage that crucial trust.
Like what? What are some common pitfalls?
Giving advice is a big one, You should just take your meds, or you just need to get out more.
Why is that bad? It sounds helpful.
Because it takes away the patient's autonomy, their power to figure things out for themselves. It implies you know better, and it can feel dismissive of their own process.
Okay, I see that. What else?
False reassurance. Saying things like, don't worry, everything will be fine.
But isn't that comforting?
It can feel incredibly invalidating if the person is genuinely distressed. It shuts down their real feelings. It's like saying, your fear isn't legitimate.
Right. It minimizes their experience.
Exactly. Changing the subject is another one. Often done because the provider is uncomfortable, maybe with intense emotion or a difficult topic.
Ah, so it's about the provider's discomfort, not the patient's needs.
Often, yes. And it signals to the patient that their concerns aren't okay to talk about. Using cliches is another, time heals all wounds, look on the bright side. They just feel impersonal, generic.
Like you're not really listening to their specific situation.
Precisely. And finally, asking why questions can be problematic.
Why? Why is why bad?
Because it can sound accusatory or judgmental. Why did you do that? Or why do you feel that way? It can put the person on the defensive, make them feel like they need to justify themselves.
Okay, that makes sense. It implies criticism.
It can, yeah.
Right.
Better to ask what or how questions. What was happening before you felt that way? Or how did that decision come about? It's more exploratory.
You also have that stark example from social media, the TikTok video.
Yes, that was a really visceral example from 2022. A nurse essentially told a crying patient, "Oh, you're just hormonal." Yeah. And the online reaction was huge because people immediately recognize how minimizing and dismissive that is.
Yeah.
It completely invalidated the patient's emotional reality in that moment. A really clear case of non-therapeutic communication causing harm.
It's so clear from all this that effective communication isn't just about learning techniques. It's also deeply influenced by context, isn't it?
Yeah, absolutely. So many factors come into play. Culture is a huge one.
How so?
Well, take eye contact. In many Western cultures, direct eye contact signals honesty, engagement. But in some other cultures, it can be seen as disrespectful or confrontational. You have to be aware of that.
Right. Huge potential for misunderstanding there.
Age is another big factor. Teenagers, for instance, might communicate volumes through body language or silence more so than, say, older adults.
Okay.
And the person's immediate mental state is obviously critical. Someone experiencing active symptoms of schizophrenia might be responding to internal stimuli, voices, visions that aren't apparent to you. Their communication will be affected by that internal reality.
And the environment itself matters too.
Definitely. Trying to have a sensitive conversation on a noisy, busy, open ward is completely different from having it in a quiet, private room. The setting impacts how safe and open someone feels.
So the takeaway here is that the clinician needs to be constantly adapting.
Constantly. Adapting their tone, their pace of speaking, their body language, even the words they choose, based on who they're talking to, their culture, age, mental status, and where they are. It requires incredible sensitivity and moment-to-moment attunement.
Okay, we've covered a lot of ground, the principles, the techniques, the pitfalls, the influencing factors. Can we maybe walk through a more specific scenario to see how this all comes together?
Sure, let's paint a picture. Imagine a 43-year-old man, let's call him John, newly admitted to a psychiatric unit. He's there due to expressing suicidal thoughts.
Okay.
When the nurse first meets him, he seems very withdrawn. Affect is flat, meaning not showing much emotion. And when the nurse tries to engage, she just says, "You won't understand."
Wow, that's a tough opening. Feels like a wall just went up. How would a nurse approach that therapeutically?
Well, first, probably using offering self. The nurse might say something gentle like, "You don't have to talk right now if you don't want to, John, but I'd like to just sit here with you for a little while if that's okay."
So no pressure, just presence.
Exactly. Then, importantly, the nurse would likely use silence. Just sit patiently, wait, observe, without feeling that need to immediately fill the space with questions or chatter.
Giving him space.
After a bit, if John remains quiet, but maybe seems a little less tense, the nurse might try verbalizing the implied, reflecting back what seems unsaid.
Like what?
Something like, "It sounds like maybe you've been feeling really alone with all this for quite some time." It's an observation, an invitation.
Okay, testing the waters gently.
And if John maybe nods slightly or his eyes flicker, the nurse could follow up with empathy, not assuming, but acknowledging the likely feeling. That must feel incredibly painful.
Just validating the potential pain.
Right. It's about building that connection slowly, showing understanding without demanding disclosure.
And in a scenario like this, what's the potential positive outcome of that careful approach?
Well, in the kind of scenario outlined in sources like Townsend and Morgan, by maybe day 3, using this consistent, patient, therapeutic approach, John might start to open up.
Really?
Yeah, maybe he starts talking about a recent difficult divorce, losing his job. Because that initial trust was built, he might become more willing to try medication, maybe even start attending group therapy sessions. It shows how that initial interaction, grounded in therapeutic principles, can pave the way for real progress.
That's a really hopeful illustration of how powerful this can be when done right.
It really is.
So as we start to wrap up this deep dive, what are the absolute core takeaways you think everyone listening should hold on to about therapeutic communication?
Okay, maybe 5 key things. First, remember, it's not just chatting. It's intentional, it's adaptable, and it's always, always focused on the patient's needs.
Intentional and adaptable.
Got it. Second, it demands true active listening. That means using your ears, yes, but also your eyes watching nonverbals and even your intuition, kind of sensing what's not being said.
Eyes, ears, and intuition.
Mm-hmm.
Okay.
Third, don't underestimate the power of nonverbal presence. Sometimes just being there, calmly and attentively, is the most therapeutic thing you can offer. Saying less can be more.
Powerful presence. Makes sense.
Fourth, on the flip side, be really aware that non-therapeutic communication, even if you mean well, can break trust almost instantly. Things like giving advice or false reassurance,
Damage can happen quickly.
right? And finally, maybe the overarching point is that meaningful healing often happens not through lots of talking at someone, but through creating a space where they feel safe enough to explore their own feelings. It's often about speaking less, but meaning more with your presence and chosen words.
That's a fantastic summary. This has been incredibly insightful, especially as we are in Mental Health Awareness Month. It just really drives home how vital creating these safe, supportive environments through how we communicate truly is.
Mm-hmm. It really matters.
So we really encourage you, listening out there, to maybe reflect a little on the power you hold in both your words and your nonverbal signals in your own interactions, whatever setting they're in.
Yeah, it's relevant for everyone.
Absolutely. And maybe here's a final thought to chew on. If we all got a bit better at understanding and maybe using some of these therapeutic communication principles,
Mhm.
how might that change our everyday conversations, our relationships with family, friends, colleagues? Way beyond just healthcare.
That's a great question to ponder.
Something to think about. Thank you so much for joining us for this deep dive today.
My pleasure.